Oh, so anyway, the correct answer for that one was just the giving non-judgmental information or whatever, however it was worded.
It was like direct or
Yeah.
indirect.
It was like not
Give indirect.
something non-formal, I'd have to look back at it. Non-directed. That's what it was. 'Cause you're not supposed to tell them what they should pick. It's supposed to be.
Yeah, I read that.
Like you're not supposed to direct them to what path they're supposed to go. You're supposed to give them the information and let them figure it out. But clearly, the general consensus is everybody was confused.
We're always
that
taught to
question
be
was
direct.
different.
So that's why.
Yeah, it's kind of a tricky one. So that one was the only one that I saw that like screamed at me that was very clearly a bad question from using my phone and scrolling through. I mean, Jenny, I don't know if you could hear when I was talking about it, but I said I'm going to get at least credit back for that one question I said.
Which question was it?
It was the one about genetic counseling and how you would what you would say to the parents for a baby that was like prenatally diagnosed.
Okay.
Okay. So we have a lot to get through, guys. So we're just going to kind of try and cover as much as we humanly possibly can.
No talking.
Okay, so this is where we left off. So we're still talking about the 5 Ps, and we're talking about mom's positioning. We've covered baby's positioning, so now we're jumping into mom's position and how it alters the progress of labor. In current standards, typically what you see is a mom not moving around, lying on her back, and it really, unfortunately, is not the most healthy. If you think about how labor progresses and how the baby's coming down the canal and all of the things that we can do to help make the progress happen in a very conducive manner, having a mom supine is probably the least natural way for a woman to give birth. Really, we should be encouraging them to assume any position that is comfortable for them. Depending on the position of the baby internally, it will alter that. If you have a baby that's OP, it's going to be very back-intensive pain for mom, and oftentimes, like, sitting forward through a lot of the labor is what's more comfortable. Having dad or having a nurse, like, massaging their lower back to kind of help relieve spasms, things like that. A lot of very nursing-driven interventions that can help alter the progress of labor. For those of you still lost on trying to find things to write about, not a bad thing to look into, because that is a very nursing-driven area. Changing positions and moving around during labor offers a whole lot of different benefits. The position that the mom is in can very much drastically influence pelvic size and contours. You'll start to see those like big bouncy balls around the unit up in Great Falls. They're really good about that. They call it the peanut, and it looks like a big giant peanut, and they have moms sit on it and rock, because sitting with her legs kind of widened changes that pelvic proportion pretty significantly. Walking around obviously is going to put a lot more pressure on getting baby to descend into the pelvis because we're using gravity to help things. It also affects pelvic joints, kind of along those lines about facilitating that fetal descent and rotation. Sometimes it's more comfortable for mom to be on her side as baby's turning that corner. If you have baby trying to come, doing that extension underneath mom's pelvis, having mom in a crunched position of sitting forward is not going to be comfortable and not going to promote getting that baby bend underneath that pelvic bone and out. However, if you have her sitting on a bouncy ball and you've got her hips spread open and she can really rock through it and help that baby to descend, or maybe have her on her back momentarily so that baby's not fighting, certain directions. It makes a big difference. Squatting really does enlarge that pelvic inlet and outlet diameter, so as baby is meeting each of those milestones, sometimes having mom do squats, will help, because again, you're widening that pelvic opening, you're allowing gravity to help that baby come down. Back before we really started delivering in hospitals, women delivered standing up. because gravity helped all of that. It made pushing a whole lot better. You think about the position you're in when you poop. You don't poop lying down with your legs in the air.
Alan?
I was waiting for something from that back corner. Sometimes having mom kneel will actually help relieve some of the pressure of that baby on the vena cava. Having mom on all fours a lot of times really helps because it gets that baby suspended from her. So all of that back pressure, especially on a mom that has a baby that's OP, you put her onto all fours, and now all of that pressure that was sitting on her back is gone. All of this is nursing driven. These are all huge nursing interventions that completely change a woman's perception on how painful, how successful a laboring process can be. All stuff that is within our capabilities, none of it requiring a physician's order. Now, this being said, all of this comes with a huge caveat. A lot of this goes out the window the second we get an epidural, because now they have no feeling and no control of their musculature below the waist. So, kind of the give and take of some of modern medicine. We kind of have to balance that. But again, also a big education piece for us before we encourage a mom to go and get an epidural, or if they're really asking for one. The psychological response. These are also more factors that are going to influence whether or not this is going to be a positive birth experience. So providing clear information on procedures, making sure they have support and that they're not alone in this. Not everybody has a significant other that's there with them the entire time holding their hand. Especially being near the military base, there are a lot of times, labor is not a planned process. Babies come when they decide to come. So I would say there's a fair amount of time that dads are out in the field, hours away, before they even get the call by the time mom's even getting to the hospital, and then they're that much further out, while mom's now laboring in a hospital bed completely alone, because they're away from their home, they don't have family close by, if baby is early or late, or they may not have family support around. So making sure that they're not alone in this is huge. Encouraging a sense of mastery and self-confidence, that they can do this. If you have a mom that really wants to do this naturally without pain meds, not everybody has Ed standing there encouraging them and telling them they can do this. I mean, his wife was lucky that she had somebody who was so supportive of that decision and that he had no problem standing up to, his in-law saying, no, she's got this, it's okay. That's part of our role, is to encourage them and tell them they can do this, they can push through this. Having them trust the staff, because that's a huge responsibility. That's 2 lives that they're entrusting to you. It's not just mom's life, not just baby's life, it's the whole package. Whether or not they're having a positive reaction to the pregnancy. If they've been sick the whole time, there's a good chance that they're coming into this laboring process just wishing for it to be over. Not everybody has a wonderful pregnancy. If this was a product of rape, that puts a whole new level of emotional stress on the laboring process. Whether or not they can have personal control over their breathing, and this becomes a link to kind of that Lamaze technique, as well as whether or not they've been prepared for what they're entering. Because there's not a whole lot of public information about what to expect when you're delivering a baby. There's a lot of books out about what to expect when you're expecting and being pregnant and the first year the baby's around, but there's not a whole lot out there that tells a family really what to expect from the moment that water breaks or the moment they get admitted to the hospital until they get discharged. And not knowing is sometimes the scariest part. Maternal catecholamines can really inhibit uterine contractility and placental blood flow. So if you've got a mom who's pregnant and may or may not be in a place where they're prepared for this and they go into labor, you bet your bottom that those stress hormones, those catecholamines, are through the roof. That in and of itself is inhibiting the natural relaxation process that has to happen for contractions to occur properly, for baby to descend through the canal appropriately. So de-stressing a mom in labor helps immensely in having that whole process go smoothly. There's probably a fair amount of research out there about how having a nurse at the bedside or having a doula or having somebody there to help them cope through each of the stages of labor makes a big difference on the outcome, on cesarean rates, on vaginal birth rates, that kind of stuff. And it really does become our responsibility. And the conservation of energy is also really important. There's a lot of times where moms want to get up and they walk and walk and walk and walk, trying to get this baby to descend, trying to get herself to dilate. And they spend hours walking in circles around that unit, and they burn so much energy that by the time it comes time to push, they're exhausted. So finding that balance of doing things to promote labor and conserving her energy, because that pushing process is going to take everything out of her. The physiologic responses to labor on the mom's end of things. These are normal things that we expect to find. I encourage you to know these, because how do you know what is abnormal if you do not know what is normal? This is not normal for you and I to walk around with a heart rate of 110, but it might be normal for a woman in labor. Her body is stressed and it is working really, really hard, even if she's just lying in bed. So tachycardia, not necessarily something to be concerned about. An increase in cardiac output, an increase in blood pressure during contractions, and that's important. A slight elevation in blood pressure is considered normal because she's working harder. An increased white blood cell count, somewhere between 25 and 30,000, is considered normal. In your everyday nursing career, if you saw somebody with a white blood cell count of 27,000, what would that tell you? Infection. Hint, hint, probably a big focus on your boards. If you have a pregnant person in labor with a white blood cell count of 27,000, you need to know those normal levels. Because it might trigger you to say, oh, I'm really worried about her because she's probably got an infection for her. No, she probably doesn't. The inflammatory process that goes along with labor is why those white blood cells are elevated. It's normal. Increased respiratory rate and oxygen consumption, again, because that metabolism is through the roof because they're working really hard. They have a decrease in gastric motility and food absorption because their body says, I don't need my intestines right now. That doesn't really matter. Odds are they're not eating while they're laboring. However, that also increases the risk for nausea and vomiting because if nothing is moving from here down and you eat something, odds are it wants to come back up, especially with a contraction. You now have an abdomen that is seizing down on everything that's in there. If they've eaten a huge meal, where do you think that meal is going? It is coming right back at you. It's not uncommon for women in labor to puke, which is also one of the reasons why when you're in the hospital setting, they don't let them eat. The second they come in and that IV goes in, food is off the table. They get ice chips. When you have these women that are laboring for 23 hours, they got nothing left. Important for you guys to remember that kind of stuff because there's a reason they're getting pooped and tired. You know, they don't have any sugar reserves. They got nothing left. Decreased gastric emptying and gastric pH increases. So now we have more of a damaging effect if they aspirate when they vomit. So those moms that are having an emergency C-section where it's not a controlled setting, that's the other reason why they're not allowed to eat in the hospital setting because if the labor doesn't progress normally as expected and they have to go back for a C-section, they don't have time to wait 6 hours for their stomach to clear. You know, in the home setting or in a birth center setting, they don't worry about that stuff as much because if they puke, they puke. But if they're eating and it makes them happy and that's more normal for them, then it's fine because to them it's a normal pregnancy. It should proceed appropriately. They're not preparing for the what if of a C-section. A slight temperature elevation is normal. An elevation above 101.4 is a key number to remember because that is one of the biggest triggers for chorioamnionitis as a diagnosis. So 101.4, anything below that is really reasonable. A temp of 100.7 is fine. 101.7 is not. Muscle aches and cramps, completely normal. Again, their system is depleting everything they have trying to get this baby out. So they're going to be dehydrated. They're going to have low sugars. What happens to your system when that is going on? A, you're cranky, and B, your muscles hurt. And then that decreased blood glucose level. On the baby end of things, baby is reacting to the laboring process. There are certain things that we expect, and there are certain things that we hope not to see. Things that we expect to see. Periodic fetal heart rate, FHR, is fetal heart rate. You expect it to see accelerations and slight decelerations related to movement, fundal pressure, and uterine contractions. You want to see that the baby is responding to things that are irritating it. you're getting a acceleration in fetal heart rate because it's moving around. If you go from lying on your back to standing up, what happens to your heart rate? It goes up. You want to see the same thing to baby. It's getting shifted from left to right. It's going to have the same exact reaction. If it's kicking its arms and its legs around, it's moving. It's going to increase its heart rate. We want to see that. You also want to see, minor decelerations are okay, and we'll get more into the specifics of that when it comes to things like fundal pressure and uterine contractions. Because what happens to baby's blood supply when a uterine contraction happens? It gets cut off. What else gets cut off when their blood supply gets cut off? Oxygen. When oxygen is depleted, their heart rate declines, just like it would in you and I. The reason you pass out when you hold your breath too long, one of. So we expect to see slight decelerations in that instance. You do see an increase in arterial carbon dioxide pressures, as well as a decrease in fetal breathing movements, and all of that is going to relate to the actual delivery, and we'll get to that a little bit later. You're going to see decreases in fetal oxygen pressure as well as partial pressure of oxygen within the blood. And that's because, A, mom is breathing heavier because she knows that there's less oxygen getting to baby. Baby's getting compressed during those contractions, less is getting over to it. That increase in arterial carbon dioxide pressure happens in order to stimulate baby to breathe when it comes out. You don't think about all of the things that are leading up to that initial that baby has. They haven't been breathing before, and one of the ways that our bodies know how to prepare the baby for that is to increase those carbon dioxide levels, because that's a trigger to breathe. If baby's carbon dioxide levels stayed low when it got delivered, it wouldn't care. It would hold its breath in order to get those CO2 levels to come up. So as a result, that's why you see this arterial carbon dioxide pressure. That's the purpose behind it. Stages of labor. So this is going to be very important for you guys. There are certain components of it you have to memorize because they will also explain to you why we do the things that we do as nurses. But you need to be able to recognize what stage a woman is in when they're in labor, as well as the expectations of our nursing management specific to those stages. So the first stage is the longest and the most variable stage that we see. It begins with the onset of regular contractions, by definition, true labor, which is why you had to know the difference between true and false labor. And the first stage ends when the cervix is fully dilated and effaced. So we have 10 centimeters of dilation and 100% effacement. That's the end of stage 1. This stage of labor, being that it's so variable, is a lot of the reason why when somebody wants to know how long they're going to be in labor for, you say, I don't know. If I had that crystal ball, I would be a millionaire, and I wouldn't be teaching, and I'd be sitting on my yacht in the middle of the Pacific. Because it is so variable, and it completely depends on everybody's body is different. How they react to pregnancies is different. Just because they've had a baby before doesn't mean that they're going to know exactly how long they're going to be in labor the second time or the third time or the fourth time, although I will tell you, typically, they get shorter. So if you have somebody that had a 3-hour labor start to finish, you better expect to have them in the hospital fairly early, because it's not going to take them 3 hours the second go-around, usually. That being said, there are variances between babies. We had a mom in not that long ago who had 4 girls that were all 6 pounds, delivered vaginally. They all went beautifully, got pregnant with a boy, ended up with a C-section because he was 90. Wow. They don't all progress the same way just because they have gone that way in the past, and that becomes important because a lot of times people get pregnant and then they assume that it's just going to progress the exact same way, and it doesn't. The first stage is broken down into 3 different components. There's the latent or early portion of the first stage, and this is where it's really slow. This is where the contractions start with some regularity. True labor, by definition, has actually started, and it lasts until the cervix has dilated to 3 centimeters. This can take days in somebody who hasn't had a baby before. It can take hours. It might take 12 hours. It might take 2 hours. It completely depends on the position of the baby. Typically, contractions are usually mild to palpation. You remember how we know mild? No? FYI, you guys, I think almost all of you got that right. The chin was the answer. They do occur about every 5 to 10 minutes. and they last approximately 30 to 45 seconds. Do you guys remember how we're measuring the frequency of contractions? We talked about that last week.
Second.
Right, beginning to beginning. So if they're having one every 5 to 10 minutes, that means you're measuring it from the start of the contraction to the start of the next. So not that often, but often enough to be an irritant, a nuisance. They're still able to focus very clearly, and they're receptive to education. So it would be awesome if we had them in the hospital at this point in time, but that's not when we tell them to come. Unfortunately, having them in the hospital room for hours and hours and hours and days and days and days on end, insurance doesn't really look too kindly on that. So, as a result, we try to get this education in when we can, but odds are you don't usually see people in the hospital at this point in time. The active stage of labor is when those contractions are now stronger and they last longer. And the reason that you're starting to see other changes is because those contractions are more effective. So you're seeing cervical dilation. Now they're going to be more like 4 to 7 centimeters, and they're starting to get to be about 40 to 80% at base.
And they're not.
Not necessarily.
So, but what if it has? So they have time to have fetal heart rate, and then you send them home with return?
They might. Yeah, you might send them home if their water's broken. Well, and we'll kind of get to that, because there's a length of time that we deem acceptable for water to be broken before you worry about AFib infection. So most of the time, if their water's broken, they're parking themselves in the unit, usually. Or you'll see the triage nurses here are really good about it if their water's broken, but they're not really dilated and they're not having very effective contractions. They'll say, we'll call the physician with the results. Why don't you walk around a bunch? And they'll have them do a whole bunch of laps, and then they'll come back and reassess them, and oh, look, now they're 3.5 or they're 2.5 centimeters dilated. They're not actually in the active phase yet, but they're making changes. And typically at that point, they'll admit them. But a lot of it boils down to the triage nurses that are here. And they're good at what they do. So we're pretty lucky on that regard. In the active phase, contractions usually increase to a more moderate to strong palpation. So we're looking at that chin to forehead. They last somewhere between 45 and 60 seconds, and they occur every 2 to 5 minutes. So much closer, much stronger, much longer. I still encourage them to walk around as they're comfortable or until they're ruptured. Typically, they're more inwardly focused, and sometimes they almost like shut you off, like they don't really want to be bothered. They just kind of quiet and focus on themselves because, to be honest, the contractions don't feel that great. You know, they're sort of trying to focus and breathe and just get through it, knowing that things are real. Sort of this is the time where they start to cope with the fact that they're actually about to try to push a baby out their vagina. The last component of the first stage is the transition phase, and this is where the cervical dilation continues. It tends to be at a slower rate, but eventually they do become complete, so at 10 centimeters and 100% effaced. Contractions are hard to palpate, so you've got that forehead feeling. They last 60 to 90 seconds in length, and they occur every 1 to 2 minutes. And this is where that memorization is going to come into play. You have to know those numbers. I cannot stress to you enough when it comes to the length of a contraction and how frequently they occur. You have to know those numbers, because that will tell you down the road, A, what stage they're in, and B, whether or not things are going the way they should be and whether things are safe. The average rate of fetal descent is about 1 centimeter per hour for somebody who's never been pregnant before, and about 2 centimeters per hour for a person that's had multiple babies. Now, that being said, I would love to say everybody progresses that way. That is what your boards care to know. That is not what you see in real life. And that's when we're talking about that station, where baby is measuring. They do tend to have an increase in rectal pressure. So this is the family that has been ruptured, and she's lying in bed, and she's getting contractions, and, her mom sticks her head out of the room, and she's like, just so you guys know, she's getting upset. She has to poop. And you're like, crap, and you're running in there, because the second they say that, you're going to end up delivering a baby in a toilet. If they're at that point, and they're feeling like they have to poop, it's not that they have to poop, it's that they have to push. And it's the same sensation. Typically, they'll also have some nausea and vomiting. Trembling is very common. You see that a lot, where it's like a sympathetic nervous system hyperstimulation, and they look like they're having the chills, and inevitably their significant other or some family members are like piling blankets on them, and they're sweating. They're having backache, because think about where that baby is right now. Increased apprehension and irritability because they are uncomfortable and they're hurting, and again, the reality of the fact that they're going to have to push this baby out of their vagina is very real. They're typically very restless. Sometimes they have an increase in bloody show. They'll get kind of a gush of blood as things are dilating and stretching. That diaphoresis, that sweating, and they tend to feel very overwhelmed. Some of the emotional symptoms of it you'll see less with people that have had numerous kids, but this is very textbook for what you see, especially for somebody who's doing this for the first time. For the second stage of labor, it's called the stage of expulsion. Sounds wonderful, doesn't it? It starts when the cervix is 10 centimeters and ends with the birth of the baby. Now, this is important because you got to remember, in that transition phase of that first stage, they were feeling like they had to poop. That does not mean they're pushing. They should not necessarily be pushing. A woman who starts pushing before she is 10 centimeters dilated on a term baby is going to tear a lot of things internally because things are not ready for that baby to come out. Cervical tears, to repair those, are really uncomfortable. It is not something you wish upon anybody, so really they need to wait until they're 10 centimeters. And sometimes you need to encourage them to just like hang tight. Contractions at this point are typically happening every 2 to 3 minutes and lasting about 60 to 90 seconds. Oftentimes the female is starting to feel a little bit more in control and a little bit less irritable and agitated because now we're at the point where they're doing something. They're not just sitting and waiting and feeling these contractions endlessly for hours on end. Now we're getting down to the business of getting things done. They start to have that urge to bear down. A shift towards a more physiologic, woman-directed approach is really where we're going. It's a big evidence-based push right now, is that labor proceeds much more normally and much more appropriately. The risk of a C-section is far less. The risk of exhaustion is far less if we allow the woman to dictate when to push. Everybody is taught that, they see a contraction in the monitor, and now they're yelling at this mom to push and push and push and breathe and count, and everybody's yelling, and that's not the most conducive way for a woman to progress for an actual vaginal delivery. Typically, we want the woman to be able to feel the contraction. If she can feel the contraction and get this urge to bear down, they tend to be much more effective at pushing. The length of time that they're in labor tends to diminish because they are effective. When you have somebody that's not effectively pushing, what ends up happening is the second stage of labor ends up taking a lot longer, and oftentimes they get tired. And they get to the point where they really need to get the baby out because the baby's not tolerating it, and now we end up using things like forceps or a vacuum, or they end up with a C-section because they're so wiped at this point that they can't effectively push. So the big turn now is that we should be encouraging, as a nurse-driven intervention, we should be encouraging women to push when they feel like they need to.
Didn't we just say to tell them hang tight?
In that first stage. Now we're already dilated to 10.
Okay.
Is the second stage where they start turning down, like the epidurals and stuff like that?
Yep, because we want them to feel the need to push. If that epidural is too strong, they feel nada. And they think it's great because they don't feel anything, and this has been wonderful and easy. And then they take that epidural down, and it's like a light switch, and they're not very happy about the fact that it hurts. And that's usually the biggest thing we hear, especially in like really, really young moms who haven't been prepared educationally on what to expect. They get to the point where they need to push, and they turn the epidural down, and now they can feel it. They're like, it hurts. And it's like, well, yeah, it hurts. You're pushing a baby out of your vagina. Let's go. Let's talk about it. Like, it's not gonna happen. I don't want to do it. It's like, well, there's only one way it's coming out. So, fuck up. You can't say that. You'd love to, but in your observation days, you'll get some really entertaining perspectives. There are some nurses out there that have a really good knack at saying those things without sounding mean. This is when those cardinal movements are happening. This is where that rotation is happening, where the baby's coming underneath. The whole cardinal movement process that we just got tested on is all happening during this second stage of labor. It can last up to 3 hours in someone who hasn't had a baby before. Ideally, in somebody who has, it lasts less than an hour. Why the difference?
The body's used to that experience.
The body's used to it, and they know what they're doing. Big education piece. If they know what they're doing, odds are it's going to go more effectively. So if we can prepare them so that the second stage doesn't take 3 hours, because imagine, I mean, it's like doing abdominal crunches with a basketball under your skin for 3 hours every 3 minutes. How many of you are prepared to do that?
I want to take a strong pass.
They're going to be tired by the end of that 3-hour mark. So ideally, it happens faster than that, but that's kind of the general timeline. The third stage, now we've gotten the baby out. At the end of the second stage, baby's born. So the third stage is the placental separation and expulsion stage. So the third stage starts when that baby's born, and it ends when the placenta is delivered. Signs of placental separation, important for you guys to know, because it means that the placenta is ready to deliver, because it actually has to separate from the uterine wall before it's going to come out. Good for you to be aware of when that's going to happen so that it can be anticipated and helped and assisted along the way. Things you want to see, the uterus rising upwards. Not what you would normally expect, right? You're expecting the placenta to come out. Well, in order for that placenta to separate, the placenta's not attached to anything anymore. Baby's been clamped, it's not pulling on the placenta. How does that placenta know to detach? That uterine muscle goes and pulls off of that placenta. So you're seeing the uterus rising. The umbilical cord is going to lengthen, because initially, when it happens, you get that initial separation. It's going to go like this, and that cord now has a little bit more play to it. Typically, there's a sudden trickle of vaginal blood. Well, why is that? Because it just rips off the wall. And then the uterus is going to change to a globular shape, although I don't know a whole lot of people that sit there and evaluate the actual shape that the uterus is. And then the fourth stage is the stage of recovery. And this begins the delivery of the placenta and lasts somewhere between the first 4 hours until mom's vital signs are stable. So it might last longer, depending on whether or not she's having complications. We expect moms to lose around 500 milliliters of blood, so half of a liter, if they're having a vaginal birth, and about 1,000 if they're having a C-section. That's a lot of blood to lose in one sitting, pretty quickly. So we anticipate some component of a blood pressure drop as well as some tachycardia, because her body is trying to regulate this huge shift in blood supply. So a slight drop in blood pressure and a slight tachycardia is considered normal. The uterus is going to be round, and it should be a palpable mass somewhere at or below the level of the umbilicus. And this is going to be important because this becomes part of your postpartum assessment. At this point, they are actually palpating to feel that the uterus is round, because if it's not round and if it's not located at the level or below of the umbilicus, now we're dealing with the potential for a postpartum hemorrhage, retained placental fragments, because if there's any of that placenta still stuck on the wall of the uterus, what's happening? It's just bleeding, because it's just this very vascular piece of tissue that's just oozing and oozing and oozing, and if that's there, the uterus can't contract down appropriately. And so now you're going to have this pooling of blood with a whole host of other risk factors that are going to go along with it and complications that you're going to see. And we'll talk more about that as we go on. For the first hour after delivery, it is very critical for us to assess excessive bleeding and firmness of that contracting uterus for the exact reasons I was just talking about. Lochia, which is the vaginal discharge that we're going to be evaluating, should be red. It can have small clots in it, which is normal, because what's the uterus trying to do now that that placenta is ripped off? It's trying to clot. And so you're going to get these like micro clots that are going to pass, and that's normal. Those clots, typically we say we have women in the postpartum world alert their nurse if they're larger than the size of an egg or a silver dollar. It's a fairly sizable clot when you think about it. Anything smaller than that is fine. It's normal. And it should be about a moderate flow. And we'll talk about flow and how you measure that here in a second, since moderate is a fairly subjective term. So our assessment during labor and birth is going to revolve around things like vital signs, pain, reviewing their prenatal records to make sure that we don't have any risk factors for things that we're worried about, GBS status, HIV status, hepatitis B status, any of that kind of stuff. A vaginal examination that typically gets done on admission, as well as frequently throughout the process to see if mom's progressing appropriately. Evaluating for cervical dilation, effacement, membrane status, whether or not they're ruptured, fetal descent and presentation, and that's where those pictures come from when we looked at last week, that Ed so kindly pointed out the first two were wrong. To test for rupture of membranes. If they just have a whole bunch of clear fluid coming out of their vagina, how do we know if it's that their membranes have ruptured, or that they feed themselves, even though it's not coming out of the vagina, it's close enough that it can be misconstrued, or that they didn't just have intercourse and it's semen coming back out, which happens. Nitrazine is going to be how we know, and nitrazine is a little strip. It's just a pH strip. That's all it is. It starts out pink, and if you dip it in something that's alkaline, it turns blue. Amniotic fluid is alkaline, so it turns blue. What is urine? Acidic. And it's not going to turn blue. Seminal fluid can be alkaline, but it tends to be more of the mid-range, and so it doesn't turn it as blue, and typically there's not enough there to test. If the nitrazine comes back inconclusive, then we proceed to the Fern test, which is where they actually take a smear of the amniotic fluid on a slide, and you look at it underneath a microscope, and it does. As it dries, it ferns out, and it looks like the leaves on a fern. When membranes rupture, and I think the majority of you guys got this, our first priority is always the assessment of the fetal heart rate for deceleration, because decelerations mean what? Cord compression. It always means cord compression, regardless of whether it's a benign deceleration or not. But if they're having cord compression after their membranes have ruptured, there's a good chance that that's a prolapsed cord. Prolonged rupture of membranes, and this is kind of going back to what you were asking about, it does increase the risk of infection from those ascending vaginal organisms. Things and symptoms that we look for: maternal fever, that's that 101.4. Fetal or maternal tachycardia. So if you have a baby that you put on a monitor and its heart rate is 170, that's fast. There's a reason it's fast. Babies don't just sit there tachycardic. Typically, it's that mom has a fever. What do all of us have when you have a fever? What does your heart rate do? It increases because your metabolic rate's up. Baby has the same effects because the amniotic fluid in the environment it's floating in are hot. So baby gets hot. If there is a foul odor or vaginal discharge, I will tell you, you never forget the smell of choreo. It's gross. It's like fermenting. Sometimes the vaginal discharge will be green or yellow.
Yeah,
Very good indication that there's an infection.
I was talking about that girl that gave birth in her car. I've been cleaning that out.
That would be a lot of work.
I wasn't sure where you were making the cutoff, so I read all the 14 states.
Okay.
But they were saying that if it's green, it had a meconium, thank you.
That's it. So that's a different color green.
Well,
but yes.
They would have to rinse it to stain it, so.
Mm-hmm.
And
Like an amnio infusion.
so what is that? I didn't quite.
So basically, if baby is stressed in utero during the laboring process or prior, they will pass stool called meconium, and it's thick green sludge. And depending on how long they've been floating in the meconium and whatnot, typically what happens is it'll come out when mom's membranes rupture. It comes out the same way because it's staining the amniotic fluid. It looks green. They describe it in a couple of different ways. There's like thin, thick, pea soup. Pea soup's pretty particulate. That's the other way you'll hear it referenced. Where there's actually like little chunks of it floating in the amniotic fluid. All very much impact how it affects baby, because when baby comes out, baby's covered in it. And when baby goes and takes that big old breath of poop, it doesn't sit so well in the lungs. It creates a whole lot of issues, and we'll talk more about that with the newborn assessment. But one of the things that they'll do if mom has meconium present in her amniotic fluid when she ruptures, oftentimes, especially if it's thick, they'll infuse saline back up into her uterus to try to dilute it out so that it's a little thinner and not quite so viscous. So if baby were to inhale it, it isn't as sticky and tarry inside those lungs. Make sense?
Yeah.
The other thing that we'll see with an infection of the chorioamnionitis is an elevated white blood cell count. Well, where's our normal white blood cell count? 25 to 30,000 in somebody who's laboring. Kind of an important one when it comes to exam questions, because if you have somebody that has a white blood cell count of 27,000, it doesn't count for this infection risk. You're going to see moms with 40,000, you know, much higher numbers. We're going to be assessing the uterine contractions. Oh, sorry, we're going to talk about the amniotic fluid for color and stat meconium staining, because it does typically indicate fetal distress, unless baby's breech, because then every time baby gets squeezed, what do you think is coming out? Poop. Then, in that situation, it's considered normal. One of the other reasons why it's important for us to know what the presenting part is. Leopold's maneuvers, that's where we talk about where they evaluate the presentation, the position, and the lie of the baby. Typically, I've seen it where it's the OB that's doing that assessment, but for your boards, you're supposed to know that. Fetal assessment. We're going to look at amniotic fluid analysis. Sometimes they'll look at how mature baby's lungs are by looking at the amniotic fluid. Fetal heart rate monitoring. Handheld versus electronic. There's a whole bunch of different types that you can use. Intermittent versus continuous, and that becomes a big sticking point, especially when you're looking at like the home births or the birthing center births versus the hospital births, because they use intermittent far more often. Continuous tends to be something that we use in the hospital, although, again, this kind of becomes a good nursing intervention point. C-section rates are a lot higher when continuous monitoring is used, because you can see everything that baby's heart rate is doing. So if they're having a lot more decelerations, you know more. Well, does that mean that we're intervening more than we should be, and maybe that's more normal? Or does it mean that those kids really should be C-sections? Kind of a trend that we see go full circle in medicine. Typically, if they are a high-risk delivery at all, they'll have continuous monitoring, because you want to know what's going on with baby. Intermittent monitoring does have the upside that it allows for increased mobility in that first stage, because they aren't strapped to this monitor that's strapping them to the bed. The continuous monitors are the ones that are that strap that goes right around mom's abdomen with the Doppler sitting on it. Intermittent can obtain a baseline rhythm and changes, but it cannot assess variability, and it cannot assess different types of decelerations because it's not on consistently enough. And then external versus internal, the only way that we can do an internal fetal heart rate monitoring is with a scalp electrode, and it's an electrode that's like screwed into baby's scalp, basically. Mom has to be ruptured in order for that to be a viable option. And typically they'll use that in moms where they're concerned about baby's heart rate and they can't seem to keep the baby on the monitor externally. Or if they're finding that mom's heart rate artifact is coming through too much, because on the fetal heart rate, when it's screwed into the scalp, it can't pick up mom. Fetal heart rate patterns we'll talk about here in a little bit, but table 14.1 does go through it really well. And then other assessment methods that we'll talk about, that fetal scalp sampling, pulse oximetry, and stimulation are all things that are going to be important for us to evaluate, because if mom's pulse ox is going down, it means baby's oxygen is going down. And then stimulation, if baby's just resting, I mean, that's totally possible. There's a good chance the baby is resting through the first early stages of labor because it knows there's a whole lot more coming. To decipher that between a baby that doesn't have a lot of fetal heart rate variability and might be in distress, we know that because you poke and prod at it, or you stimulate mom, or we increase the oxytocin, or we do something to irritate the baby enough to see if we can get a heart rate response. So monitoring fetal heart rate. Fetal heart tones are best heard over the fetal back, so it is very important to know fetal position. Look, it's coming back again. If you know where baby's fetal position is, you know where baby's fetal back is. You have to know that to know where to put the monitor on mom. Because if the baby is facing right occiput posterior, where's baby's back? Baby's back is kind of up and over here, so you may actually hear the fetal heart rate better on the right-hand side of mom's abdomen, closer to the bottom. Now, if you have a baby that's a breech, that heart rate's going to be heard higher up on mom's abdomen. It's going to be important for you guys to know that. Those are very much questions that you can anticipate seeing on my exam, on the board. They may give you a baby's position, and they're going to want to know where on mom's abdomen you're placing that fetal heart rate monitor. Because if you can't find baby's heart rate, and you're delaying finding baby's heart rate because you can't figure out which position baby's in, Now that's decisions that may be altered because you're not competent at the skill set that you should be. You should be able to find that heart rate almost immediately, assuming baby is cooperative and staying where it's supposed to. Doesn't always happen, especially early on. You know, during labor, that baby should be pretty locked and loaded and ready on where it's positioned. That's not going to change a ton. Your textbook does have, I believe, a graphical presentation of like where you hear the heart rate. But if not, I encourage you to look back at the slide from last week, earlier in this PowerPoint, on where that fetal back is, and remember where the heart is located on the fetal back as well. Does that make sense? Any sudden changes or a measurement outside of the normal range should immediately be reported, which requires you to know what the normal expectations are for a baby going through this process. Signs of fetal distress. So loss of baseline variability. You expect that heart rate to vary a little bit, usually within 10 to 15 beats, up or down, give or take, because that's what our heart rates do. Not all of us sit at 72 beats per minute every single second of every single day. Your heart rate moves depending on what you're doing, and you expect to see the same thing with a baby. So if you have a loss of that baseline variability, that's cause for concern because it means that heart rate's not really reacting to much at all. Variable or late decelerations that persist after maternal position change. And this, I think there's a, oh, I thought there was a chart. I'm pretty sure your textbook talks about it. But variable or late decelerations are decelerations that are happening sporadically, not in relation to contractions, or late decelerations are decelerations that you see towards the end of a contraction that don't resolve when a contraction is over. You anticipate seeing early decelerations. Those are normal because when that contraction happens, what happens to the cord? It gets compressed. You expect to see baby's heart rate come down a little bit. If that heart rate persists and stays down through the whole contraction and doesn't recover, not a good sign. If you have a baby who doesn't have that in the beginning and then all of a sudden at the end of the contraction is now having a heart rate drop, that's not normal either. That's when they should be recovering. And we'll talk more about what that means later. Things that we do for that, though. Maternal position change is going to be one big one, as well as putting oxygen on mom. Because it's all related to a lack of oxygen, lack of blood supply. That's why babies have deceleration. Those are the only reasons babies have deceleration. So changing mom's position, if we get her onto the left side, that improves blood flow to baby, correct? Because it gets baby off of the vena cava. That's our biggest nursing intervention that we can do if you see a deceleration. That is what you are doing immediately before you are notifying anybody. You're doing something about it. It's kind of like walking into your patient's room with a stat of 68. What's the first thing you're going to do? Put oxygen on them. You're not going to yell for the doctor or go notify the doctor. You're going to fix it first and then go tell somebody. Same deal here. Yes, it is important to notify of any changes, but when you know exactly what the change is that you're seeing, do something about it first. And then any persistent fetal tachycardia is also a cause for concern. Fetal well-being during labor is very much measured by their response to those contractions. So guidelines that we follow for assessing that fetal heart rate. One gets done initially, somewhere when they enter the labor and delivery area, for 10 to 20 minutes. Kind of gives us a baseline of where baby's heart rate is, what they're doing, that sort of thing. We evaluate the prenatal and labor risk factors, and then every 30 minutes or so during active labor for low-risk women, and every 15 minutes for high-risk women, we should be doing an intermittent auscultation. So this is for somebody who doesn't have continuous monitoring on. During the second stage of labor, we're doing that intermittent auscultation every 15 minutes for somebody who's low risk, and every 5 minutes for somebody who's high risk. So you can see if there's a higher risk, we're paying closer attention because we're expecting something to go wrong. These are numbers you have to know. You have to memorize them because it's the expectation of what protocol and policy are nationwide when it comes to this stuff. Fetal heart rate should be assessed immediately after membranes have ruptured. Any vaginal exam because we're altering the cervix and we want to make sure that baby is tolerating things. Any kind of medication administration, pain meds, because if it alters mom's respiratory drive or it alters mom's blood pressure, it very well may be altering baby. And then with any abnormal fetal movement at all, if baby's not moving a ton and there's cause for concern, that heart rate monitor goes back on. Does that make sense so far? With continuous monitoring, it provides us a little bit more of a visual display of uterine activity. And this is those strips that you see that have the peak and the valley, and the peak and the valley, and the peak and the valley, and then the baby's heart rate is kind of tracked alongside of it. For external monitoring, that's where that tocodynamometer, I don't know why they make these words so hard, is the Doppler that they're attaching to the outside of mom's abdomen. That's the one that you need to know where to place based on baby's back positioning. We can, in these situations, we can monitor the frequency and duration of mom's contractions, but there is only one way to measure the intensity of an contraction, aside from like our objective measurements as far as like, you know, hard miles, that sort of thing. But the true intensity as a form of like an actual numerical measurement cannot be measured unless there is an intrauterine device in place. Internal fetal monitoring, that's that spiral electrode that I was talking about that's inserted into the vagina and placed on the presenting part. It can be on the sacrum as well. It doesn't have to be the fetal head. And then those wires extend from the electrode to a plate that's attached to mom's leg and then attached to a monitor. So it's like a grounding source and then the monitor. It is much more accurate, but it does require that membranes are ruptured and that mom is at least 2 centimeters dilated, because you have to be dilated in order to get it up there. The primary objective for fetal heart rate monitoring is to basically evaluate the well-being of the baby. You know, making sure that we're detecting changes before they are substantially prolonged and profound. So ideally, if a baby is compromised, we're rushing to do something about it before things get too far gone, too late, where damage is done. Our role as nurses, and this is the reason why these patients are one-to-ones, because that monitor, as long as it is on continuously, it is the nurse's responsibility. They're supposed to be paying attention to that monitor the entire time. It may not seem like they're doing a lot physically because they're sitting there, but their eyes are always on that monitor. On the OB unit in Great Falls, there are big versions of that monitor up on both nurses' stations. So if they go to the bathroom or whatever, somebody always has eyes on that monitor. We always want to make sure that it's a reassuring heart pattern. If it is non-reassuring, it means there is some kind of fetal distress. So we are repositioning mom on that left sideline. We're administering oxygen. If we need to, we're stopping the oxytocin because that may be what's overstimulating baby. The contractions may be causing the problem, and so we may need to pull back on that oxytocin. Making sure that IV stays patent in case it needs to give other medications, and notifying the provider. Nowhere in the process notifying the provider comes. There's a lot of nursing interventions that are the responsibility of a nurse to do to guarantee the safety and success of a pregnancy carried to term, to deliver that baby, that is 2 lives that are completely in her hands, to both recognize when there are problems, to manage when there are problems, and then to notify somebody for help. There is a lot that goes into being a labor-trained nurse. It is not something that just happens overnight. Those nurses get an extra 13, 16, 18 weeks of training. It depends on how long, how much they get to see, that sort of stuff. There's a lot that goes into it, and we're just kind of covering the surface. Reassuring and non-reassuring patterns, just so you know the difference. So the normal, baby's heart rate should be somewhere between 110 and 160 with no decelerations, but they may have accelerations. Now that no decelerations caveat is when mom is not necessarily in labor. Accelerations are brief, temporary increases in fetal heart rate of at least 15 beats per minute above baseline that last 15 seconds to somewhere between 2 minutes. And we've kind of talked about where we see a lot of that. You do tend to see accelerations more with breech presentations, although I'm not really quite sure why. And they tend to precede contractions and bundle pressure, almost as like a preservative method for them to they sort of bolster their supply of oxygen, knowing the contraction is coming, so that when their heart rate drops off, they've had a reserve of oxygen. So you tend to see accelerations at the beginning of a contraction, or just before a contraction. Decelerations are those transitory decreases in heart rate from baseline, classified according to pattern and when they occur. They do indicate a disruption in oxygen transfer, always. That is always what they indicate. It is not always a bad sign if you see a deceleration, however. We did talk about the baseline variability and sort of what it means. Absent or minimal, we turn mom on her side, we increase the IV rate to kind of increase her blood pressure, give her some oxygen. Moderate variability is considered a good sign. That's what we want to see. It means they're acting appropriately, they're stimulated appropriately. And then marked variability, where you have a baby's heart rate that's kind of jumping all over the place. You'll see that with things like cord prolapse or compression. If mom's blood pressure is really low, uterine hyperstimulation, so if they're having too many contractions or they're having contractions that are lasting too long, hence the reason you need to know the actual appropriate times for all of those things. We'll see it with moms that are abrupting, so if their placenta is pulling away before it's supposed to, before baby's out. Again, in those situations, we start out with the same process of what we do. Lateral positioning, increasing the IV rate, giving them oxygen, and discontinuing that Pitocin if we need to. Category 3 patterns are basically the ones that we're really concerned about as far as fetal heart rate goes. And these, again, are kind of that same or similar categories to what we were just talking about. You can read through them because they're pretty straightforward. But again, the interventions on that right-hand side are going to be the exact same things that we were talking about. Of note, that left or right lateral positioning, you'll also see them put them in the knee chest or hands to knees, because what that does is it relieves core compression. You think about it, you bring their knees up, and it opens that pelvic cavity. So now whatever's causing any kind of compression has been released. Administering oxygen, increasing the IV rate, all of that sort of stuff. And then pain management. I'm not going to go into a ton of detail because your slides really do a good job on it. I expect that you are informed and educated on this stuff. So this really should be a review for you. As far as pain management goes, there's two different types, non-pharmacologic as well as pharmacologic. Pharmacologic is typically what you think of when you talk about pain management in labor, but there's a lot of other stuff. I mean, you have breathing techniques, you have acupuncture, ambulation and position changes. All of those things are things that we can do as nurses, it's not the acupuncture techniques, but they're all things that we can offer as means to avoid pharmacologic pain management if people don't want it. Or to help people in supplement or in conjunction with that pharmacologic management. Really, we're shifting the mindset nowadays so that the woman really becomes the active participant during labor, so not snowing her from all of being able to feel everything. You know, if you remember back to what we talked about that first week and how they used to give, they used to knock moms out for deliveries, completely knock them out. And it took 4 days to recover. You know, that's why they had a nursery. We don't do that anymore, ideally. You know, I've delivered kids in the ICU to moms that are intubated that can't actually participate in labor, that they vagal down the ET tube to force her to push. I've seen stuff where that's not the case. Obviously not the ideal. We would like them to be active participants. Labor goes much more naturally, much more smoothly that way. And we'll talk a little bit about the actual specific ones. Systemic analgesia, that's where we're typically administering it parenterally through an IV, but they do have oral and IM administration routes as well. We're talking about things like opioids, so fentanyl. They can give fentanyl through a spinal, through an epidural. It is the most effective against moderate to severe pain, but we do run the risk of respiratory depression as a complication. If a mom is exposed to it for too terribly long, there is a chance that the baby would get some of that drug as well. So if it's given IV, you know, it's a good thing to be aware of that it does cross the placenta. And so typically we try to time it with the contraction. Because if you're getting it with a contraction, that cord is compressed, there's less getting to it.
Do you utilize like PAs?
Sometimes. With epidurals, they definitely do. There's an upside to those in that it is individual control. However, the downside is a lot of times people end up more numb than they need to be. Or, like in my case, you have a very helpful significant other, and you've fallen asleep because the pain has gone away, and he's pushed the button 4 more times while you're asleep, you know, because he doesn't want you to be uncomfortable. And it's like, well, that was really sweet, but I'm dead. Like, from the way, there's nothing. Like, zilch. So there's an education component to that you don't want the pain to completely go away. And not just for the pregnant person. For everybody in the room that can get to that button. Atoractics that we give, hydroxyzine and promethazine, they're really designed either to be antiemetics or anxiolytics. And so sometimes they'll give that to people who are just like so anxious that they can't relax. Sometimes those work a little bit better. They can cause a little bit of variability in newborn depression, but not so much of the respiratory component. Benzodiazepines, that's things like Versed. We use those a fair amount. But they do use, and this becomes important, specific to OB, diazepam is also given for clampic seizures, and that's the drug of choice in that situation. We'll talk more about that when we get to high-risk stuff, but that is a specific med you absolutely have to know when it comes to OB stuff. Regional analgesia and anesthesia, there's a whole bunch of these, and you can kind of see different explanations for when they would use them. The epidural block is what they used to use all of the time, although it can cause an increased duration in that second stage of labor because they can't feel the contractions. Again, they kind of increase that rate of that instrument-assisted delivery because people can't feel the contractions. And so now this stage has gotten so much longer, their pushing is less effective. There is a potential for fetal distress, more because mom's blood pressure tends to tank after it's administered. So we tend to put moms on their left side shortly thereafter, or after they get the epidural, and they'll lie them down on their left side first until their body can normalize the process. But a good nursing intervention to be aware of is there's a good chance after an epidural goes in that you may be giving a bolus of fluid to get that mom's blood pressure back up. I worked the other day, and we had a mom who was doing fine and was recovering post-op from a C-section. They sat her up, she got nauseous, she puked, vagaled herself, and her blood pressure went to 50/20. It happens fast. So you have to be on your game when it comes to this stuff. Because a lot of times the OB world seems boring. There's not a lot going on. And they're all healthy, and things are going smoothly until they're not. And then things change very rapidly on that floor, and so they've got to be on their A game. A spinal epidural block, those are more like the walking epidurals because they still maintain the ability to ambulate, but we make sure that there's always somebody with them at all times because their gait tends to be a little bit weak, and they preserve their ability to push a little bit better. There's that PCA we were talking about. Local infiltrations, they'll use that for an episiotomy or a laceration repair, and that's where they basically do lidocaine in the actual vaginal area. Pudendal blocks, they'll do an anesthetic that's actually injected into the pudendal nerve, and those have been fairly successful in that the woman can actually feel the whole second stage of labor, can push effectively, but the actual localized pain of everything stretching or tearing or the episiotomy, all of that's gone because the nerve that innervates that whole area is numb. And there's no complications associated with it at all. And then spinal anesthesia, that's usually what they use during labor, and it also converts to a C-section as well because it provides pain relief, and you can kind of minimize the numbing effects of it. But the complications that you do anticipate are very much like you do with an epidural, and they get hypotension. And because it's going into the subarachnoid space, there's also the risk of a spinal headache, and those are nasty if it happens. And we'll talk again more about that with postpartum assessment. General anesthesia we really try not to do. It's typically with an emergency C-section because it does get across to the baby. So the longer mom is under, the more sedate baby is going to be when it comes out. And any mom that is getting any kind of general anesthesia, they do better be at that delivery. Or, like Jenny in your situation, if that happens and they delivered in Shoto because they've got to knock mom out to get that baby out, those nurses better be ready to resuscitate that baby because there's a good chance it's going to need it when it comes out. Just good stuff to kind of be aware, and it does go through just the general ideas of going to the OR under general anesthesia and the steps that we would take just to prevent complications. The nursing care that we talk about in the remaining slides is all stuff that we've talked about as we've gone through it. Review it, look through it. If you guys have any questions, ask me. Please email me. I'll be more than happy to cover it in the next class, but it's all stuff we've already talked about. Especially as we've been going through, it's just a nice way to break it out for you guys for a review purpose on what is expected of you in each of those stages outside of like the physiologic changes. about? You guys have any questions? I know we just covered a whole lot of information, but next week will be a lot more. There is a quiz. I know you guys had the exam, but there is a quiz on this remaining material for next week, just like you have the first 2 weeks of the semester, exactly the same setup. So you should be good to go. Annie, do you have any questions or anything? Okay. I should have those grades out to you here fairly quickly. I don't think it's going to take a ton for me to review. I do want to tell you, Jenny, now that they're all busy and stuff, I did want to let you work pretty darn well.
So, sorry, I didn't hear you.
Oh, it's okay. Here, hold on.